Carter. Here. Hadsma.
Here.
Neely. Here. Glanville. Here. Kafia. Here. Conlon. Here. Farhat.
Here.
Fitzgerald.
Here.
Miller. Here. Reingen.
Here.
Vanderwall.
Here.
Filler.
Yes.
Mueller.
Here.
Van Workum. Roth. Schmaltz.
Here.
Thompson. Madam Chair, you have 16 members present. You do have a quorum.
Thank you. Representative Glanville moves to approve the minutes for our meeting on October 12th. Seeing no objection, minutes are approved. Today we have a full agenda, so we will try to move efficiently through testimony and votes. First, we will hear testimony from Rep. Pohutsky on her bill HB 5027 so that she can return to chair the House Natural Resources, Environment, Tourism, and Outdoor Recreation Committee. We will then hear a brief presentation from the Michigan Department of Health and Human Services on the newly announced Advancing Healthy Births, an equity plan for Michigan families and communities. Then we will vote on SB 513 and House Bill 4276, which does have an H3 substitute. We will not be voting on telemedicine bills today, which were HB 4131, 4213, 4579, and 4580, but rather we'll continue working on them with stakeholders. I will be sending two bills, House Bill 5178 and 79, related to substance use prevention and safety to the House Behavioral Health Subcommittee, and we will be hearing testimony on bills in the maternal and infant health care package. First up, we have House Bill 5027 from Representative Pohutsky, and we have herself, as well as Ashley Svensson, a genetic counselor, who will be joining us virtually. Welcome, and begin when you're ready.
Thank you very much, Madam Chair. And after you had to give the title of the committee, I'm officially out of time. So I will be very brief. Thank you, Madam Chair and members of the committee, for allowing me to testify in support of House Bill 5027, my bill that requires non-invasive prenatal testing and expanded carrier screening to be covered for all Medicaid patients. Non-invasive prenatal testing, also known as NIPT testing, is expanded carrier screening. Our screening tests offered during pregnancy to see if the fetus is at risk for having a chromosomal disorder or serious genetic disorders. Chromosomal abnormalities occur in approximately 1 in 150 live births, and the incidence of fetal chromosomal abnormalities increase as the patient ages. But to be clear, they can affect pregnant people of all ages, and it's not related to race or ethnicity. This testing offers the earliest and most accurate screening in order to ensure that patients have the necessary resources in place at delivery and are as prepared as possible to navigate any possible challenges that they may have once they bring their baby home. In the past, these tests have only been recommended to pregnant people that were considered to be high risk. This legislation would codify a decision made by Michigan Medicaid to access the NIPT screening regardless of risk. The American College of Obstetricians has updated their clinical guidance to recommend that healthcare providers offer all pregnant patients the option to have NIPT screening done. The vast majority of private health providers and several other state Medicaid plans have expanded their coverage to align with current guidelines from ACOG and include coverage for NIPT. However, there is still a glaring gap of patients who don't have access to this screening in Michigan. This creates a health disparity between pregnant people with insurance and financial resources and those without. It's imperative that we provide the same standard of care to all pregnant people, regardless of their socioeconomic status, and this policy is part of state statute. Much like NIPT, expanded carrier screening is designed to give individuals and couples, regardless of their background, a comprehensive and accurate understanding of their risk of passing on a genetic disorder to their child. Access to expanded carrier screening is working with providers, patients, and payers to ensure that this screening panel is widely available to everyone. And it's also important to note that those facing financial hardship are often the least likely to have an accurate familial genetic history. So therefore, they're actually the most in need of carrier screening. So at this time, I'd be happy to briefly take any questions, but I will probably be deferring more technical or medical questions to the providers in the room that can answer them more accurately.
Thank you so much. Does anyone have any questions for a representative? Okay.
Thank you so much.
Thank you for joining us. Next up on Zoom, we've got Ashley Svensson, a genetic counselor, joining us virtually.
Hey, all. Can you hear me?
Yes, we can. Thank you for joining us.
Okay. Yes, excuse me. I'm joining from a conference today. So thank you so much for this opportunity to comment in support of HB 5027. Again, my name is Ashley Svensson. I'm a board certified genetic counselor with over 20 years experience. Prenatal screening is a long-standing component of reproductive care that enables prospective parents to make informed choices about their reproductive health and optimize birth outcomes. As these genetic technologies have evolved, the testing that has available has become more precise and more comprehensive. This bill will ensure that all prospective parents in Michigan who elect to undergo screening will have access without barriers, and it will allow healthcare providers to offer care in line with their professional society guidelines. Specifically, I want to point out the importance of carrier screening for recessive and X-linked diseases like sickle cell and cystic fibrosis. This is truly an equity issue. Michigan is one of 3 states where Medicaid beneficiaries have no access to reproductive carrier screening. Second, in Michigan, most people with commercial insurance do have access to expanded carrier screening, so this is really creating a dual standard of care. So I strongly encourage you to support House Bill 5027 so that pregnant patients in Michigan, in particular Medicaid beneficiaries, have access to equitable prenatal care that's in line with published evidence, medical society guidelines, and this will help to close the gap of healthcare inequities in the state. So thank you so much for the opportunity to make this comment.
Thank you for joining us. Do members have questions? Going once, going twice. All right, thank you so much. We do have some cards to read in. Supporting the bill is the Bonnell Foundation with cystic fibrosis. Also, Dr. John Fox with Illumina. Supporting the bill, Michigan League for Public Policy. And supporting the bill, Michigan Council for Maternal Child Health. Next, we have we'll hear a brief presentation from the Department Division of Maternal and Infant Health with the Michigan Department of Health and Human Services, Dawn Shanafelt, on the newly announced Advancing Health Births and Equity Plan for Michigan Families and Communities. And I believe you had a handout presentation at our desks as well. Welcome to Health Policy, and begin whenever you're ready, and thank you for accompanying Sade.
Thank you so much. Good morning, and thank you for the opportunity to discuss the Advancing Healthy Births and Equity Plan for Michigan Families and Communities. I'm Dawn Shanafelt, the Director of the Division of Maternal and Infant Health, and also Michigan's Title V Director for the Michigan Department of Health and Human Services. Michigan has released plans to address infant mortality for 50-plus years. In the fall of 2019, the Mother-Infant Health and Equity Improvement Plan was released. This was the first plan to address the need of improving infant and maternal health. It was created with direct advisement from Michigan families, rooted in the requirement to acknowledge and eradicate long-standing inequities and to take action. That plan was successful in unifying our efforts and making collective strides in creating a foundation to improve maternal and infant health. On October 2nd, an updated version was released, the Advancing Healthy Births Plan. We are accelerating our efforts and solidifying the foundation to advance healthy births. Continuing to strive towards the strategic vision of zero preventable deaths and zero health disparities, Michigan's plan focuses on sustainable actions and multifaceted approaches to improve outcomes for birthing people and their infants. While birth outcomes have improved in Michigan, disparate outcomes persist. In 2021, 656 families experienced the death of their infant. Black and Indigenous pregnant and postpartum individuals and their babies continue to experience higher preventable deaths. Only in listening to Michigan families as experts on their lives and their communities will our goal of zero preventable deaths and zero health disparities be achieved, an equitable Michigan that all birthing people deserve. Michigan families and communities know the solutions to improve birth outcomes. Barriers to health must be removed. This takes time and ample, consistent investment. The Advancing Healthy Births Plan was created in partnership and under the advisement, as I said, of Michigan Families. 12 town hall-style discussions were hosted by the regional perinatal quality collaboratives and held in communities throughout Michigan in April and May of this year. The regional perinatal quality collaboratives are truly community-based, collaborative in nature, and solution-focused. The plan includes the following 5 goals. If our Michigan infant mortality rate is reduced to 6.0 deaths per 1,000 live births, 74 more Michigan babies will survive each year. 74 families will not experience the life-changing loss of a child. 3 additional kindergarten classrooms will be filled with laughter, excitement, and the promise of children. The remaining goals include reducing the eclampsia rate, and the symptoms of eclampsia are high blood pressure, headaches, blurry vision, and convulsions. Continuing to reduce the teen birth rate, increase the number of doulas available to be part of the care team. And I want to mention that doulas do improve birth outcomes. And since the launch of the Michigan Doula Initiative in January 1 of this year, I'm happy to share that 257 doulas are now on the Michigan Doula Registry. And our final goal is to assure implementation of the Alliance for Innovation on Maternal Health, known as Michigan AIM, hypertension safety bundle at 90% of Michigan's birthing hospitals. The strength-based priorities of the plan are health across the reproductive lifespan, full-term healthy weight babies, infant safely sleeping, mental, behavioral health, and well-being. Across Michigan, all partners can employ actions that can be found within the Advancing Healthy Births Plan. Simple solutions cannot effectively address long-standing public health and societal challenges rooted in inequities. Alignment, collaboration, and investment will ensure we all work toward the same goals, resulting in healthy and just birth outcomes. So once again, thank you for the opportunity to speak, Madam Chair. I'm happy to take questions if time permits, as well as share the contact information for the MDHHS Director of Legislative Affairs, Sharday Burton, for additional questions or comments too.
Thank you so much for your presentation. Very informative. Representative Thompson has a question.
Yes.
Thank you, Madam Chair. Just two simple questions. How do you plan on reducing the rate of teen pregnancy?
How do we plan on reducing the rate of teen pregnancy? Well, we've already been successful in doing that. So I think to continue reducing the rate, because we have proven effective ways of reducing teen pregnancy. One is education, understanding the biology of pregnancy, which happens in schools around the country, and as well as providing services that are available for teens to make decisions regarding pregnancy.
Such as
decisions regarding pregnancy, understanding their, I'm a nurse, so understanding their menstrual cycles, knowing when they can or cannot get pregnant. I think that's really important for them to know that, and having access to contraceptive methods if that's what their interest is.
And then with relationship to the preeclampsia, I am a nurse as well.
Oh, great.
So with preeclampsia, I know that, it's hypertension, it's protein in your urine. What are some things that we can be doing to help prevent that in our minority communities?
I think one thing that is really important is equitable access to environments and a society that promotes healthcare. So those would be things such as the ability to safely and freely walk throughout your community without concern, reduction in stress that's imposed on Black and Indigenous communities daily, the ability to have access to healthy foods. And by access, I don't simply mean that there's a farmer's market down the road, but that you have access 365 days a year. And that access includes transportation, the financial means. So it's a host of things that will help reduce that.
Thank you.
Any other questions? Seeing none. Oh, Minority Vice Chair Vanderwall.
Thank you, Madam Chair. Appreciate it. And again, thank you for being here. I guess a couple questions. First off, when we look at your report or what your goals are, and we talk about teen pregnancy, we talk about pregnancies in underserved areas, and we talk about Black women have 2.8 more times. Have we done any studies in the economic areas that are inner city that are primarily Caucasian, and are those rates similar? Are they still a wide range of difference? And then the other part is through this, there's no talk about what the true cost of a program like this would be to roll it out statewide. If you could answer those two questions, it would be greatly appreciated. Thank you.
Absolutely. So there are disparate outcomes no matter where you look in the state. So if you're looking at, you mentioned inner city urban, if you look at the data, and we have data available on our website, and I'm happy to share that as well. But if you look at the data, there's disparate outcomes. It cuts across for Black and Indigenous pregnant and postpartum people, it cuts across to income level. So it's there, and it's not the result of race. It's the result of racism, quite frankly, and systemic inequities. And then your second question was regarding the cost. There are, as I said, it's multifaceted. So there are numerous programs and efforts coming together to help improve maternal and infant health outcome. To quantify that would be extremely difficult. You can quantify it based on program. We know the cost of, so for the fiscal 24 budget, we're advancing maternal and infant health outcomes by increasing the standard of care and quality of care with Michigan birthing hospitals, supporting the hospitals, a non-punitive stance, supporting them to elevate standard of care. We know the cost of that. That's in the budget for $10 million. So I think to collectively come up with a number to eradicate poor maternal health outcomes and to have zero disparities, I think that's impossible at this point, quite frankly. I think we're making steps, is what I'm trying to say. This is a long-standing problem, and we're taking steps to dismantle it.
And I understand that, and I'm not trying to get it. We just can't willy-nilly make a decision and put something in and pass laws without knowing some financial burden that the state is going to have, so we can be somewhat prepared.
Exactly.
And I feel very strongly that we need to make sure that we have at least some general numbers. We know that it's 10 million now. You know, we worked very hard in the last term on the doulas, and we know the importance of coaching and what that's done. So not coming across opposed, I'm just questioning, we have to be prepared of what we can do inside a budget to make sure that we adequately at least have a start. And I guess those are the things that I challenge back and ask if you can work with us on that and help us all in this committee understand what we're looking at. Thank you.
Thank you.
Thank you. Representative Filler.
Yeah, House Bills 51, 67, and 68, I believe they deal with blood pressure monitors. And can you talk to us about the process and why this is necessary?
Representative Filler, we're going to actually hold that question for the bill sponsors. If you have a question directly for the presentation, that would be great. Okay, we will come back to you later. Thank you. Representative, seeing no one else, Representative Thompson has a follow-up.
Thank you very much. On a positive note, I did have my certification as a doula. I've helped 6 women give birth.
Amazing.
I'm very passionate about natural childbirth and breastfeeding, so I implore you for doing that. So in the lines of that, and I would love for you to continue your work in educating women generationally, because I think when I was a young mother and I became involved in more of a natural childbirth and breastfeeding, I tended to listen to what my mom said and what my grandma said.
Absolutely.
And what we need to be doing is changing that and not listening to maybe the old stories. And doulas will help provide that. They'll help provide that they're a strong woman. Their body was meant to give birth. God made them to give birth. So this is what I love that we're doing that. Something I would like to see, and I had asked the question in another committee. You do work for the Michigan Department of Health and Human Services?
Yes, I do.
Do you know where we are at with our WIC program? Because the frustration that I have and have always had is that we know that breast is best for immunity, for jaw development, for SIDS, for postpartum depression. Why are we not educating our mothers in these low-income communities on the benefits of breastfeeding, and we're just giving them WIC money to go buy formula? Can we do better?
So I am not the WIC director, but I will share, because we work closely, given that I'm the Division of Maternal and Infant Health Director, we work closely with WIC. WIC has made great strides across the country and advances in the promotion and education and the support of breastfeeding. So WIC covers lactation, I'm going to get the terminology wrong, so I'm sorry, but lactation support at the WIC clinics throughout the state of Michigan. They also have a 1-800 line to call for support that includes breastfeeding support and linking to breastfeeding services. And they also, again, the WIC director would be better to answer this, but they do assist with breast pumps and breast pumping supplies. Not that that means that we're promoting solely pumping breast milk, but that means when individuals need to pump, for work or for attending school or for some other reason, or a baby in the NICU, they have access to the breast pumps. So there's definitely a pendulum shift, and we can have the WIC director reach out and share more information.
Because,
they're doing great things.
Respectfully, that hasn't been my experience in Wayne County. My daughter
Sorry
had
to hear
WIC,
that.
and she just got her every 3 months money added to her card, her food card, but she never had to go to the department to get any type of education whatsoever.
Thank you, Representative Thompson. Sharday is very good at connecting us with our folks at DHHS, so we will get you the right person to get connected with the WIC program and get you more answers. Thank you so much for your presentations. We do have some votes to get through, so I appreciate your testimony. We will be voting on, let's see, Representative Vanderwall moves to report Senate Bill 513 with recommendation. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witset. Yes. Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Cuffia. Yes. Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingans.
Yes.
Vanderwall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Workum.
Yes.
Roth. Schmaltz.
Yes.
Thompson.
Yes.
Madam Chair, you have 18 yeas, 0 nays, and 0 pass. Senate Bill 513 is reported with recommendation.
Next, we have House Bill 4276 with an H3 substitute. Representative Farhat, would you please join us out front and the table and give us a brief description of the changes as you have in your sub?
All right, thank you, Chair and members of Health Policy. So the sub just clarifies the intent of the initial boilerplate. It adds on, I have this right here, on line 4, page 1, Michigan before the word pharmacy. On line 7, page 2, Michigan before the word Medicaid. And on line 21, page 2, Michigan, is, again, another time before the word Medicaid. And the reason we did that is we want to clarify that the dispensing fee and this reimbursement methodology is for Michigan-based pharmacies that are receiving the reimbursements for Michigan Medicaid plans. We want to make sure that that's clarified in the statute and that there's no conflict with any out-of-state providers that might be taking advantage of our Medicaid plans. So that was the reason we did
Thank
that.
you so much. We have one card of support. Michigan Health and Hospital Association supports the bill, and I believe that Representative Filler will move to adopt the H3 sub to HB 4276. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witset.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Cuffia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingans.
Yes.
Vanderwall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Workum.
Yes.
Roth. Schmaltz.
Yes.
Thompson.
Pass.
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 Madam Chair, you have 17 yeas, 0 nays, 1 pass. The substitute H3 is adopted.
Representative Conlon moves to report House Bill 4276 with recommendation as substitute H3. Madam Clerk, please take the vote.
Chair Rogers.
Yes.
Representatives Witset.
Yes.
Carter.
Yes.
Hadsma.
Yes.
Neely.
Yes.
Glanville.
Yes.
Cuffia.
Yes.
Conlon.
Yes.
Farhat.
Yes.
Fitzgerald.
Yes.
Miller.
Yes.
Reingans.
Yes.
Vanderwall.
Yes.
Filler.
Yes.
Mueller.
Yes.
Van Workum.
Yes.
Roth. Schmaltz.
Yes.
Thompson.
Pass.
Madam Chair, you have 17 yeas, 0 nays, 1 pass. House Bill 4276 is reported with recommendation as substitute H3.
House Bill 5178 and 5179 were introduced and referred to the Committee on Health Policy. It is my intention to have Chair Braybuck and the Behavioral Health Subcommittee work on these bills. Madam Clerk, please read in the provided letter.
The letter is dated October 19th, 2023. Dear Madam Clerk, on October 18th, 2023, House Bills 5178 and 5179 were referred to the House Committee on Health Policy. House Bill 5178 would permit the creation of needle and hypodermic syringe access programs. House Bill 5179 removes fentanyl testing strips and other tests to determine if toxic or hazardous compounds are present from the definition of drug paraphernalia. I am asking the Subcommittee on Behavioral Health to review and make recommendations to these bills. The deadly opioid addiction crisis is a threat to our public health. I am confident that the subcommittee will be successful and productive. Sincerely, Julie M. Rogers, Chair, House Committee on Health Policy.
Thank you, Clerk. As we heard on September 28 and in the presentation this morning, infant and maternal health outcomes are of great concern in our state. As such, we will be hearing testimony on a package of bills to begin to address the crisis in infant and maternal health. This package includes House Bill 5027 as represented by Representative Pahutsky. We will now proceed to additional testimony on bills in this package. First up, we have House Bill 5167 and 68, which relate to coverage for blood pressure monitors for pre- and postpartum individuals. To speak to the bills, we have Representative Neely and Dr. Carrie Bell, OBGYN. Representative Neely, thank you for joining, and begin whenever you're ready.
Thank you, Madam Chair. And hello, and thanks you all for having me here today. I would like to reiterate what my colleague has said about the importance legislation on maternal and infants' health. Within these bills, House Bill 5167, my bill, would grant pregnant and postpartum mothers the opportunity to receive Medicaid coverage for a purchase of a blood pressure monitor. House Bill 5168, introduced by my colleague, Rep. Edwards, would touch on private insurance and their coverage. Why is blood pressure monitoring is so important to expecting and postpartum mothers? During pregnancy, a woman creates more blood to support the fetal growth and development. If the blood pressure goes up during the pregnancy, it can place extra stress on the mother's heart and kidney. This can lead to heart disease, kidney disease, and stroke. These bills are about minimizing the risk to the mother and baby, providing access to tools necessary to take preventative actions and provide increased opportunities to monitor babies' and mothers' wellness. Both Medicaid and private insurers should cover blood pressure monitors. These bills are a must to take necessary steps to make sure pregnancy and postpartum period are safe for everyone. Thank you for letting me talk to you guys about these bills today.
Thank you. Representative Filler had a question.
Yeah, really simple question, which is, I guess I question whether it's cost effective, and maybe you can speak to that, to send everyone home with a monitor instead of giving them to people who are high risk or actually have the high blood pressure. So just a question for you.
Good morning.
Good morning.
Thank you, Representative Neal. Thank you, Madam Chairman, for the Chairperson, for the opportunity to speak today. My name is Dr. Carrie Bell. I am a clinical associate professor at the University of Michigan in obstetrics and gynecology, and I am here to express my support for HB 5167 and 5168. This vital legislation will increase care access, care equity, and the quality of care for all pregnant and postpartum people, not just the high-risk patients. With the necessity to change our practice because of COVID and the pandemic, we know that we can incorporate telehealth as a key strategy to improving prenatal care access for all of our birthing people. We have done work at Michigan Medicine and work across the state to use telehealth to make care accessible, particularly in populations who historically have been marginalized by race and racism, those living with low incomes, those with transportation issues, and those facing barriers to care. However, for telehealth to be effective, meaningful, and safe, people need to have a blood pressure monitor. While worldwide maternal mortality is decreasing, in the United States of America, worldwide mortality has increased from 20.1 per 100,000 live births in 2019 to 32.9 per 100,000 live births in 2021. We are the only first world country where maternal mortality is going up. Hypertensive disorders of pregnancy are among the leading causes of maternal mortality for pregnant and postpartum people, and it is the #1 killer of our Black birthing people. Importantly, there is a lot before maternal mortality. There are increased risks to both the pregnant person and to the baby. Mothers and birthing people have increased risks of seizure, of kidney disease, and of liver damage. The placenta can separate from the uterus. Babies can be small, there can be less fluid around the baby, and babies have a higher risk of being admitted to the NICU. Blood pressure monitoring is the way by which these orders are identified. You speak clearly or correctly, Representative Filler, that there are high-risk pregnancies that really should have blood pressure cuffs. However, about 40% of people that end up with preeclampsia did not have any risk factors. I saw someone in the office on Tuesday who said the worst part of her birth experience, this is a 39-year-old, highly educated woman of color, was that she was diagnosed with blood pressure because I sent her in for more monitoring. I was monitoring her because she was advanced maternal age. I wasn't monitoring her because she had high blood pressure. I was looking for the problem, and I found the problem, but she felt great. So now that she's pregnant again, she doesn't know what to watch for because she wasn't having any symptoms at that time. The CDC reported in 2022 that hypertensive disorders of pregnancy have increased from 13% in 2017 to 16% in 2019. Some other studies show that as high as 20%. These conditions can affect about 1 in 7 hospital admissions, and they are detectable. Dr. Alex Peel at Michigan Medicine has worked locally and also performed a national listening tour where she spoke with over 110 individuals from 25 different organizations. And the disparity for uptake for telehealth or telemedicine was the inability to have a blood pressure monitor at home. So for pregnant and postpartum patients, a blood pressure cuff is the next best step. At Michigan, we have a process. Initially, we had a grant when COVID first started, and now we have a way that we can help people get their cuffs. Some of it is covered with insurance. We educate individuals at the office. We fit them. We make sure they're accessible. We ask them to demonstrate that they can take their blood pressure, and we give them the parameters where we want them to call. Some people still do have to pay out of pocket, and sometimes that expense is not always attainable for people that have Medicaid or other commercial insurances. To give you an example of what this looks like, I get a portal message from one of my clients who is in Ferndale. She has 3 kids. She checks her blood pressure, or she doesn't check her blood pressure yet. She calls and says she has a headache, but she gets headaches all the time. She has no vision changes, no pain up underneath the right ribs. The baby's moving well. She's not bleeding. She's not cramping. She's not leaking any fluid. I ask her to check her blood pressure. It's 120/70. Great. We talk about some strategies. She can go through her typical mechanisms to help her own headaches. She'll recheck her blood pressure in an hour. If it's normal and she feels better, she stays home. She doesn't have to get from Ferndale to Ann Arbor. If she's feeling worse or her blood pressure goes up, she knows that she either needs to get to the closest emergency room or she needs to come to Ann Arbor. She has the power to gather information about her own health at home. For some people, the cost is not a barrier. That is a true statement. But for others, it is one more thing in a list of very important things. Lots of people have very important things on their list, and the cuff doesn't get up high enough. Blood pressure in pregnancy and in life can be silent, and it can be deadly. By providing anticipatory guidance, educating people on how to use it, and telling them what values are normal and abnormal, this is an important element of pre- and postpartum care. Pregnancy is a window into my future as someone assigned female at birth. People with hypertensive disorders are 50% more likely to have cardiovascular disease. This is the #1 killer of people assigned female at birth. It's the #1 killer of everyone. And for women, I just looked at the numbers before I came in today, 100,000 deaths over cancer. People will die of cardiovascular disease. This is not only an investment in pregnancy, but I wish we could think about this as an investment in life. My job is to tell people not to throw the thing away, because they can use it for the rest of their life. And for outpatient monitoring as we get older, this is standard of care for blood pressure. There are lots of interfaces for people with congestive heart failure and heart disease where they're monitoring at home and they're calling their care nurse to give them their blood pressure. Thank you for the privilege of speaking to you today and for your consideration of this legislation.
Thank you for your testimony. Are there any other questions? Representative Filler, do you feel like She did touch on yours. Are you?
No, I don't believe my question was answered. Do you want me to ask
Sure,
it
ask
again?
it one more time.
Sorry, let me try this again.
I think so. If 40% of people who have no risk factors end up with preeclampsia, that makes it difficult. Yes, the high risk patients sure should get it. I'm afraid I don't have the numbers to tell you, and I apologize. I wasn't prepared with that data. If we could think about this as an investment over the lifespan, I think it makes the cost much less. We do have to ensure that the devices are quality devices. That's a true statement. So I will need to defer to my colleagues who are doing this work on the financial piece to give you that information more clearly.
Thank you.
Thank you.
Any
Thanks,
other
Chair.
questions? Minority Vice Chair Vanderwall, and then Ryan Gins.
Yep, thank you, Madam Chair. And again, thank you for being here. And just kind of a follow-up on Representative Fillers, as we talk about this, and you incorporated telehealth, I get a little nervous because this is exactly where we think that telehealth has an issue because of the lack of opportunity for telehealth for people to actually be into a doctor's office so that you can see what the alternative is. If somebody's a high risk for high blood pressure and you're monitoring them on a regular basis, my question is, shouldn't they actually be coming into the office? You have an opportunity to visualize what you see, their facial expressions, if there's swelling in their hands or toes. I guess just chat a little bit on that for me to make me feel a little more comfortable, please.
Sure. I've been involved with telehealth the entire time. Part of that is because Dr. Peel nationally has been spearheading revamping prenatal care, which has not been revamped since 1931. We don't have any other part of medicine that has not had any overhaul for almost 100 years, and a lot has changed since then. You are correct, and it isn't a substitute for coming into the office. So the way it works in my practice, at least right now, they're coming to my office, they're bringing their cuff, and I'm seeing them 3 times, sometimes 4, before I do a telehealth visit. And when COVID first hit, it was acceptable because we were all in this unknown space. So if I needed to do a prenatal visit without a cuff, I could. Personally, it doesn't feel that way anymore. If they haven't gotten on a scale and they haven't taken their blood pressure, I'm like, okay, well, I could have called you by phone. It's not as meaningful of a visit. So I think you're valid in expressing that concern. And for the low-risk patients, when I already have 3 or 4 blood pressures before I'm sending them home to check it at home. They've already verified it once in the office. For the chronic hypertensive, they probably already have a cuff at home, and they're monitoring their blood pressure before they even get pregnant. I only will do about 3 telehealth visits in the course of the 9 that I do. So most of the time they are coming into the office. And if there are any concerns that I don't feel I can navigate without seeing them, I ask them to come in. It's not I don't want to say it's a we know we can leverage it in a meaningful way, but I don't think anyone is, ACOG supports telehealth as part of prenatal care, but we're not saying that face-to-face visits aren't important. Am I answering your question? Y'all are a little nerve-wracking, just for the record.
You're doing great. You're doing a great job.
We're not trying to do that. I get the importance, my experience was only as the husband, and the potential dad.
You're very important,
right? In the future, that our experience, we didn't have telehealth, when my children were born. However, the experience that we went through, my wife and I together, and the importance of the doctor visit is we would know exactly how much the baby had grown because of measurements. It gets very difficult to do some of that on telehealth. And as we really focus this entire committee today on the number one, making sure that we reduce the mortality rate, I mean, that's a number one priority. And I get very nervous if we start switching too much of this into a practice to make it convenient for the sake of convenience, because I think in the long term we can damage that outcome and those numbers of what we're trying to correct. I think what the representative was talking about with the blood pressure, I think we all know we monitor, a lot of us self-monitor because we have some of those issues. but the growth for the baby, you know, how's the mom doing? What has she done in lines of weight? What have we done? There's so many other aspects to this. In certain cases, convenience is great with telehealth, but in the long run, certain aspects in the same time during pregnancy, I think telehealth could be detrimental to the health of the baby and the health of the mom. So that's really what we're trying to drive at here, is that certainly we want to make sure there's convenience, but the ultimate goal here through this legislation is that we reduce the mortality rate. We make sure the experience for the mom is the best it's ever been. So that's really what I'm trying to drive at with the questions. So I appreciate you being here, and please don't take it that we're trying to drive at you.
Oh,
So-
no, not, I mean, I said that jokingly, but you are intimidating. Legislature is a little intimidating. To your point, there really are, I only see people 3 times. And again, if I have any question, I bring them in. There are people who will never be candidates for telehealth, but also know statewide, at least at University of Michigan, our MFMs are able to provide care up in the UP that they would not be able to do in person because they're able to do some of this telehealth. So there will be people that won't qualify. There are also people I flip. So they start out and they're like, I really want hybrid. And I'm like, listen, I'm sorry, you can't. And I measure fundal height. And I measure that at every visit. So I am a firm believer in the physical exam. I also spend most of my time in the postpartum space. So Dr. Peel has spent all of her time in the antepartum or the prenatal space. I spend my time in the postpartum space. And having this cuff antenatally also allows them to have it postpartum so that they can get some data at home and we can keep them at home with their newborn and only bring them in if we need to. If they can't, if a person's not able to measure their blood pressure or their cuff is giving erroneous data, they're not a candidate for that. And then we bring them to the hospital. So I don't want anyone to think that we are being willy-nilly with maternal health, because we are not. And if there's any reason to bring someone into the hospital, that is my first recommendation, or to my office.
Thank you. We have several other questions I want to get to. Would it be fair for you to use the word complementary? Telemedicine is complementary to in-person office visits?
Yes.
Thank you. Representative Reingans, then Whitsett, then Glanville. Representative Reingans.
I have a comment and then a question, and I'm not sure who can answer my question. So my comment is that today's topic is really timely and personal to me. My daughter turned 7 today. It's the 7th anniversary of her being extracted after 3 days of being induced for having really high blood pressure. And so I was having to go to Meijer, the local Meijer, because I did not have a blood pressure cuff at home. So multiple times I had to go to the maternal emergency room to get my blood pressure tested. But I also had to go to Meijer like 3 days a week because I didn't have a blood pressure cuff. And so when I was in the hospital after the, birth extraction of my daughter, they gave me a blood pressure cuff. I had great insurance at the time, so thankfully it was covered, and I still actually have it at home. But if I would have had it before, I wouldn't have to figure out how to get to Meijer after work, to get my blood pressure taken. So I think it's really important that we do give people blood pressure cuffs. And my question related to this is just that these 2 bills are like 2 sentences each. They just require these to be covered. They don't mandate that everybody's given one. I hear you advocating for everybody to be given one that is on Medicaid. Where is that decision made? We are not mandating that today. This is just, if we approve this, if it's signed into law, they should be covered if they are given, but where is it said that they must be given? I think that's a Medicaid policy.
Rep. Neely, do you want to take that one?
Yeah, it doesn't say that it must be given. We just want to make sure they have the opportunity. Mm-hmm. And if it's in the bill already saying that, it can be covered, that it's covered. And I'm very private, and I usually don't like to put out any of my business, but I had the same experience you did with my second child. And had I had the blood pressure cup, I started out fine and great. And the blood pressure got really high that we had to get to the hospital. I didn't know it was blood pressure. It was so high that, they wasn't even sure if they can get it down. And they told my husband he might have to make a choice between his wife and his unborn child. So this is very important legislation, and it should be considered. And I know you have to ask the hard questions, and I don't have a problem with that. But there's so many women that looks like me that has such a hard time with pregnancy. I was fortunate to have good insurance, but everybody's not as fortunate as I am. So I'm fighting for those particular women. So consider those women that don't have the opportunity to have affordable insurance as I do. So this is very important legislation. Didn't want to get emotional up here today. Didn't even want to share the things that I have went through because I'm just private like that. But this is so important. And I want you guys to really consider this legislation and the people that look like me that may not can afford it. Thank you.
Thank you for sharing, Representative. Representative Whitsett.
I think we're trying to make this newer than what it really is. I had my son over 30 years ago, and I was on Medicaid. And we didn't have telehealth, but you had a third line, and I had preterm labor. I was allowed 3 contractions an hour. Anything over that, I had to be rushed to the hospital. So with that being said, I had to do the weigh-in, the blood pressure, all of that. This is not new. So this is not new for doctors. I think we're just trying to make this harder than what it really is because we've just talked about it because of the pandemic. Doctors are not doing their job. They're not substituting this out. You're going in. And anyone who's definitely pregnant, if you're having problems, you're going to go in. This is just an extra tool to ensure that that actually happens and that you're on top of it. Because I'm telling you, as that person that's pregnant and you're going through that, that is the scariest moment from, I don't care, going from your home to emergency, not knowing what your blood pressure is, not knowing what's going on in that given moment. So let's just not make it, harder than what it is. That was over 30 years ago. And that, like I said, preterm labor, extremely high-risk pregnancy, in labor my entire pregnancy. Thank you.
Thank you, Vice Chair.
If I could just put out there, I still have to have my blood pressure monitored. I have a blood pressure cup at home right now, and I have to do it every day, and I have to make sure my doctor knows what's going on with me. So it is very important. Thank you.
Thank you for sharing. Representative Glanville.
Yeah, I just wanted to follow up on some of the comments I heard about whether the convenience of this, and I just want to maybe switch that word over to access. We just heard a few of my colleagues talk about that and having to drive to Meijer. We heard earlier about the stress levels, how impactful that can be on pregnancy and on the, and so I'm thinking to be in the comfort of your own home, to be able to check that blood pressure whenever you need to, feel like you want to, or when you have a doctor's appointment, would be much less stressful than having to get to a doctor's appointment once a week, twice a week, whatever it might be, having to go to Meijer in the interim to figure it out. So I think there's a little bit more to it than, like I said, it's not necessarily just a convenience. It's really about having the access to the medical care that you need during your pregnancy, so that your doctor has the full set of data they need to make the decisions, and you do, and your family does as well. So I just wanted to kind of point that out. Thank you.
Thank you. Last question goes to Representative Conlon, and then we're going to move along.
Thank you so much for your testimony. Thank you, Madam Chair. And yeah, I had a niece who went through this with preeclampsia, and it was very scary for all of us. But how common is it? That's just my last question, because it feels like it's a pretty common condition, unfortunately, for pregnant women.
Thank you, Representative Conlon. So preeclampsia is part of hypertensive disorders of pregnancy, and it ranges from 13 to 16 to 20%. So basically 1 in 5, roughly, it accounts for about 1 in 7 admissions to the hospital. It is interesting how access and convenience are linked. I would ask all of you, as I would ask myself, how often do you go to the doctor? What happens when you know that something's wrong? You opt not to get care. Is it convenient to have a cuff at home? Sure. It doesn't mean you don't get care. It just means maybe we've taken down one barrier to allow you to get the care that you need. But people that are working 2 jobs, they just don't get it.
Thank you. Thank you for your testimony. We're going to read in some cards. Supporting 5167 is American Heart Association. Supporting 5166 and 5167 and 5168 is Michigan Council for Maternal and Child Health. And supporting 5166 through 5173 is Michigan League for Public Policy. Moving along, we next have testimony on House Bill 5166, introduced by Representative Young. And to explain her bill, we have Representative Young along with Vern Davis Anthony and Kizzy Montgomery from Region 10 of the Perinatal Quality Collaborative. If you would all like to join at the tables and begin when you are ready. Thank you so much.
All right, and good morning. Thank you so much, Madam Chair. Thank you to the committee. I'm grateful to be here on this morning. This is important legislation. And my House Bill 5166, it will codify the Michigan Perinatal Quality Collaboratives, the PQCs, in support of the work that the Department of Health and Human Services started in 2015. PQC's model is designed to improve outcomes for families during the preconception, pregnancy, birth, and postpartum periods. This is an evidence-based and nationally proven model that every state in this country has and is one supported nationally by the Centers for Disease Control. In current practice, the PQCs divides the state into 10 prosperity regions so that the solutions are based on the unique needs and challenges facing the families of those regions. From Region 1 in the Upper Peninsula to Region 6 in the Thumb area to Region 10 in Southeast Michigan, the concept is to promote quality efforts, advance equity, and provide care and support during pregnancy and after. The PQC model allows DHHS to collaborate with other entities such as health family facilities or agencies, health professionals, local health departments, home visitation programs, insurers, community-based organizations, and federally recognized tribes to engage families and provide resources. My bill would require DHHS to maintain this model of care based on the work it is currently doing in our 10 regions, and to promote quality improvement efforts, to identify processes, mobilize resources, implement and expand care for families affected by perinatal substance use disorder, and expand and improve access to quality and respectful care and support throughout the pregnancy and afterward. It is important to note that our current year budget provides $10 million, which has been referenced earlier, in funding to provide grants to local collaboratives to support PQCs for every region in the state. Like the other bill sponsors in this package, I am extremely supportive of efforts to improve maternal and health outcomes in the state for all moms and for all babies. This is important to me for both being a woman and for being a woman of color. The statistics and disparities in maternal health treatment and outcomes for Black women like myself and other women of color are alarming and very disturbing, but the truth of the matter is it does not have to be that way. And so this is what my bill does. It presents an opportunity to advance a proven strategy to improve outcomes for all families in this state. And then just going off script a little bit, because that's just what I do. Right? So I don't know how many of you all are familiar with this movie, this documentary on Hulu, Aftershock. And it tells the story of these 2 African-American women who experienced crises during childbirth. They actually lost their lives. And it didn't have to be that way. Because unfortunately, there continues to be these implicit biases that come into effect. I've heard the word racist and racism since I've been sitting here, and I've heard, does it just apply to Black folks, and what about white women, and all of these things, but But the data doesn't lie. The numbers show that Black women die more often. So then we asked the question, why? Well, many times it's because nobody's listening. These two women whose lives are, gone over, what's that word, y'all? Yes, I'm tongue-tied. It's been a weird kind of day. Their lives, they had healthy pregnancies. And then when something happened, they would say, something doesn't feel right. But nobody listened because over time, I don't know how many people are aware, but there's this thing where Black women are thought to be able to not have pain. that we're supposed to have this really high tolerance for pain and don't require pain medication, that we can have surgery without anesthesia, that we can do all these things. It's not true, but unfortunately it shows up in our care. And then because it shows up in our care, it shows up in outcomes, like losing your life by doing something as simple as what God created us to do, which is give birth. And so that's why we're here today, to codify what's already happening and happening really well in our state. We've been doing this since 2015, and we can't afford to gamble with anybody's health, maternal and infant health. We just can't afford to gamble. And so why not make certain that we're the legislature that codifies this and gives our moms, gives babies the assurance that Michigan cares and that we'll do what it takes to keep us all healthy. Thank you so much, Madam Chair.
Thank you. I think we're going to hold questions after all three of you present.
Thank you, Madam Chair.
Is your microphone on? Just turn the red button. Thank you.
Yep. Thank you, Madam Chair and other members of the committee. Very pleased to be here with the opportunity to talk about what we do within a regional perinatal quality collaborative, which we represent Region 10, and I'll talk about that in a few minutes. But I just wanted to, again, thank you. This is historical for me. I was actually around when the Public Health Code was passed in 1978 that created the local health departments. So, as the wheel turns, here I am, supporting a very important bill that helps to codify the regional perinatal quality collaboratives. I want you to take a look at this picture and look at the eyes. What do the eyes tell us? Searching for safety, searching for love, needing protection. Where is my mommy? I am vulnerable. This is why we do the work that we do. This is the leadership team we call ourselves SEMQUIC, Southeast Michigan Perinatal Quality Improvement Collaborative. Of course, I'm Vern Anthony, the lead consultant. The co-leads is Alethea Carr, who was the former maternal child health director for the state of Michigan, and Dr. Iris Taylor, also a nurse, as I am a nurse, who was the president of Detroit Receiving and Hutzel Hospital, here in Detroit. And I also served as the former public health director for the state of Michigan, as well as for the city of Detroit and Wayne County, and a whole lot of stuff in between. So that's our leadership team, and you've met Kizzy, who's the director of SEMQUIC. Thanks, Kizzy. Who are we? This is a map that shows the 10 regions around the state. We are Region 10. Region 10 is Southeast Michigan. We serve Wayne, Oakland, and Macomb counties. We are laser focused on reducing disparities in maternal and infant health outcomes, which then improves outcomes for all mothers and families in our region, to have adequate access to quality and timely care and the opportunity to thrive, the opportunity to live and grow and work and contribute to your communities and families. Who are our partners? As a collaborative indicates, it's not just us. We really work with and through our partners in Southeast Michigan. health systems. I want to mention parents and families because we've created a process where we listen. We listen and learn. We learn from our families and parents and the community. We have health plans. Of course, they're the payers. If they're not at the table, a lot of decisions can't be made. Faith-based organizations, many maternal health programs, medical and behavioral health providers. I have to mention several physicians that are very active in our collaborative and, you know, provide that clinical leadership, but also are learning a lot from being at the table with parents and community organizations, and certainly our state public health. I have to mention Dawn Schonefeld and her department that just presented, but also the 3 local health departments in our region are active. So that's who we are. Now, what do? What we do is work to change some of the root causes, some of the systems that are inherently inequitable. And we've talked about that, others have talked about that. Many of our laws and policies that we have today were really based on a time when slavery was actually legal. And a lot of that has still filtered into how we deliver services and how we think, what policies are made, what laws are made, who benefits, and who doesn't. And we also work to provide resources for mothers and families to help improve their maternal outcome. We work with health systems and physicians by providing implicit bias training. And also we work with the MyAIM, Michigan, oh gosh, forgot that acronym, but MyAIM, which is a program where hospitals throughout the state agree to implement certain bundles of care to prevent maternal death. You know, it is evidence-based, bundles that relate to sepsis, for example, bundles that relate to hemorrhage, which is a major cause of maternal death, looking at issues of equity. So we work with the MyAIM program to assure greater accountability and perinatal outcomes. And I'm very pleased with our hospitals in Southeast Michigan, since they all participate in MyAIM. And we are glad to work with them and through them to assure that more women live.
Thank you so much for your testimony. We're going to have to move over to Kizzy. Well, we have a limited time, so if you want to wrap.
Kizzy's not going to present.
Okay.
I'm going to finish.
So about 1 to 2 more minutes, and then we need to move along. I'm sorry.
All right, moving on. Why we do the work that we do, and I'll just focus on the photos because we've heard the statistics. That is Dr. Harris, one of our own, who died at about 8 months pregnant. She was a physician in our community. She died. Her baby died 3 days later. That was a preventable death. It was due to heart disease. Somebody else has mentioned the impact of heart disease. Our vision, a healthy newborn baby that's able to celebrate that very precious first birthday. Moving on. I just want to talk 1 second about the Detroit Health Equity Resource that we have created with funding from Kellogg Foundation, where we have created a database that includes health data as well as social determinants of health to help providers and others and community-based organizations be able to measure what they do based on the data that's available, as well as resources on equity. Voices for Life is a project where we have trained over 100 Black women in Detroit to be able to tell their story. We videotaped about 20 of those, telling their story in their voice, their truth about their perinatal journey. The most common theme we hear is that they felt that they were not heard and that they were disrespected. And those videos are available for anybody that would like to use them to share. Partnerships and programs, 1 minute. You see Dr. Edgar Van, Bishop Edgar Van, who's a faith leader in Detroit, who has worked with us on our campaigns, especially as it relates to COVID outreach. Moving on, because I know I'm out of time. Thank you.
Thank you so much. Do we have
Be
any?
glad to take any questions.
Any member questions? Thank you so much. Do you, Representative Thompson?
Thank you very much. It's wonderful to see that you're doing this for families and giving women a voice. That's incredible. So were you a practicing nurse, you said? Did you work at Hutzel?
No, I worked in public health. I was a public health nurse when I was nursing.
Okay. I thought you said Hutzel. I was just going to ask what your experience was.
Yeah, one of our co-leads was the president of Hutzel Hospital and Detroit Receiving Hospital.
Okay. All right. Thank you.
All right. Thank you so much. You're dismissed. Next, and I have a couple of cards to read in. So supporting this bill is Michigan League for Public Policy, as well as Michigan Council for Maternal Child Health. Next up, we will hear testimony on House Bill 5172, which provides a voluntary designation for levels of maternal care at hospitals, introduced by Representative Glanville. And if all the speakers could come up together, that would be great. So Representative Glanville and Dr. Vishali Bhargava, Chair of the Michigan Section of American Congress of Obstetrics and Gynecologists. And in addition, we have Amy Zagman, Executive Director of the Michigan Council for Maternal and Child Health. Welcome, and begin whenever you're ready.
Thank you, Madam Chair, members of the committee. I just want to say, to start out, I am proud and humbled to be a part of this package and the important work that we're doing here to advance maternal and infant health outcomes here in the state of Michigan. So quickly, HB 5172 will establish levels of maternal care in Michigan for birthing hospitals. So referred to as both levels of maternal care and maternal levels of care, this effort builds on a collaboration of the Joint Commission that accredits hospitals and the American College of OBGYNs. Through self-assessment, a hospital can verify the level of maternal care it can provide based on the complexity of its patients and its available resources, both staff and equipment. 16 other states have adopted this approach and created state guidelines through statute or rule congruent with the criteria established by the Joint Commission and ACOG to incorporate levels of maternal care into their perinatal systems and create formal connections with the other efforts we've been hearing about, like the Regional Perinatal Quality Collaboratives and the Michigan Alliance for Innovation with its safety bundles focused on hemorrhage, hypertension, and sepsis. This is not a certificate of need process like trauma or NICU levels, but rather a voluntary registration that hospitals can seek and then share their level designation with the public. It is not an effort to disparage any birthing hospital or imply that hospitals with low delivery volumes, like those in rural communities, are not safe for care for women with low-risk pregnancies. Many births are safely managed at those hospitals every year. We need them to remain open. We appropriated funding in the fiscal year 24 budget to provide incentive funding for hospitals to engage in quality improvement process like this, so the timing is perfect to ensure that we are not encouraging hospitals to do something they cannot afford to pursue. Establishing levels of maternal care in Michigan will help us make the best uses of the amazing medical resources we have in our state, identify where additional resources may be needed, and most importantly, can save the lives of birthing individuals by helping direct those with the highest need to the highest level of care as quickly and as efficiently as possible. And I'd like to welcome my guests here to continue with testimony.
I'm Dr. Vishali Bhargava. I'm a lifelong Michigander, and born and raised in Kalamazoo, and a board-certified obstetrician gynecologist based in Troy. An associate professor of obstetrics and gynecology at the Oakland University William Beaumont Hospital School of Medicine. I am also representing the American College of Obstetricians and Gynecologists, and I serve, as you mentioned, as the chair of the Michigan section. ACOG is the governing body and source for clinical standards of care for the specialty of obstetrics and gynecology. ACOG is a nonpartisan organization representing more than 950 OBGYNs in the state and more than 600,000 OBGYNs nationwide. I'd like to use my time today to reinforce why the maternal levels of care verification program is beneficial to hospitals, healthcare professionals, and patients. Maternal mortality and severe maternal morbidity, as we've been hearing all along today, particularly among women of color, have increased in the United States. The leading medical causes of maternal mortality include, as we've heard, cardiovascular disease, infection, and hemorrhage. Although healthcare providers are working hard to reduce this morbidity by optimizing in-hospital care, more can be done to improve the system of care for high-risk women at facility and population levels. The goal of levels of maternal care is to reduce this maternal morbidity and mortality, including existing disparities, by ensuring that pregnant and postpartum individuals receive risk-appropriate maternal care. This program aligns with the national standards developed by both ACOG and the Society for Maternal Fetal Medicine. Establishing maternal levels of care enables the growth and maturation of systems to ensure that the maternal fetal dyads can be triaged to facilities with risk-appropriate care. Standardizing maternal levels of care also help hospitals identify and fill gaps in capabilities and personnel to best meet the needs of their patients. Further, the maternal levels of care fosters collaboration among hospitals and health systems by helping these systems establish plans for transferring care based on risk and allowing mapping of the geographic distribution of maternity care resources to identify needs for improving access to care. This standardization and opportunity for regional collaboration is vital for our patients and our efforts to reduce the alarming maternal morbidity and mortality rate in our country and state. Collaborative relationships and clarity of maternity resources and distribution will enhance the ability of people to give birth safely in their communities while providing support for circumstances when a higher level of care is needed. As an obstetrician, too often on labor and delivery, I witnessed the need for and the benefits of maternal levels of care. I recently took care of a pregnant patient with preeclampsia, which we've heard is a too common condition in pregnancy, and it is associated with elevated blood pressure, sometimes severe, and can increase the patient's risk of having a stroke or a seizure. After delivery, this patient did indeed suffer a stroke while in her hospital room. She was immediately taken for imaging of her brain, but eventually had to be expeditiously transferred to another facility for a higher level of care. Her infant remained at our hospital. In this instance, the mother's risk of morbidity and mortality was negatively affected by her hospital choice, and the dyad of mother and baby had to be separated. In my position, I often see patients who arrive at our hospital having had prenatal care at another health system and believe that all labor and delivery units are equal. As we know, this is not the case. While we can't, as OBGYNs, always predict the need for high acuity care, we can often based on some underlying high-risk conditions. When higher risk pregnancies can be triaged to match pregnant people with their delivery needs, and when hospital capabilities for caring for high-risk conditions are clear and transparent, and urgent transfers can be expedited, Michiganders benefit because we as obstetric providers are better able to get them the care they need and deserve. I appreciate the opportunity to testify in support of House Bill 5172 on behalf of ACOG and most importantly my patients. I'd be happy to answer any questions regarding the need for maternal levels of care from the perspective of an obstetrics provider.
Thank you so much. Amy, did you want to say anything? Okay. We'll go right into questions, and you can help be the team field guide if we need it. I do have one question myself before we get to Representative Filler and Reingans. I have had a couple stakeholders reach out on this bill, and I just wondered if anyone has an idea of how this would be implemented. There is already federal guidelines through the Joint Commission on Accreditation, and so we've had several stakeholders wonder if this would mirror that or which standards would be used.
Yeah, I can answer that. Thank you. The council is the one that has sort of been requesting this legislation on behalf of many of our partners, including the Michigan section of ACOG. Excuse me. If you look at subsection 5 of the bill, it makes it clear that if the department would be given rule promulgation process, but that it would be done in cooperation with the entities that are listed, and that it would consider the levels of care established by the Joint Commission and the consensus document from ACOG.
Thank you.
That's what it will be based on.
Thank you.
But we can't, in Michigan, pass a statute and simply say that we'll just do what the Joint Commission says. That's an improper delegation.
Understood. Thank you so much. Representative Filler.
So we have a national level of verification that the chair just mentioned that hospitals go through, and then we're going to create another level of verification, and then so we'll have a state level and a national level, and they will not necessarily mess up or match up. Is this how I'm?
That's not the intention, Representative Filler. Both are voluntary
but it could be,
at this
right?
point.
It could be. Because
Representative Filler, will you let her answer the question?
I do want to go into what you just said, which is hospitals will tell or sort of, I don't know, put their best foot forward or whatever, and the commission can accept it or can go a different way. So you could, with the verification, so you could get national and state that don't match up.
That's certainly not the intention, right? The intention would be, and if you read the Joint Commission's website with regard to maternal levels of care verification, they want states, they encourage and anticipate that states will pass guidelines that incorporate the Joint Commission standards and add sort of local, so add state nuance to it. It's not our intention. And I think certainly funding that's in the state budget would allow for the state to help hospitals with the cost of the Joint Commission process. But this isn't intended to be duplicative. And the state would be incorporating the Joint Commission verification if a hospital chooses to pursue that as part of the criteria for the state level. I'm probably not doing a great job explaining, but I don't think it's possible that you would have a hospital that would receive Joint Commission verification and not meet the criteria that we're envisioning for the state level of care. It's not the intention to have those not match, but what we would like to do is have in statute, like 16 other states do, state level guidelines that talk about levels of care in Michigan for hospitals that choose not to go with the Joint Commission verification. There would be a state process.
Follow-up? Okay, thank you. Representative Rankins.
Thank you. My question is about, ACOG talks about the 4 levels of maternal levels of care, but also about accredited birth centers. And it sounds like this bill does not talk about birth centers because those are accredited at a different level, at the federal level, like you're talking about. Is there a role, and I guess this question's for you, is there a role at the state level for state quality assurance of birth centers in Michigan? I know we're working on one in Detroit, but there's not widespread yet. So is there a role for the state? And I don't know if this bill would be the place to do it, but just asking about that.
My understanding is that there will be separate legislation with regard to licensing freestanding birth centers. They're not envisioned in the ACOG levels of maternal care. It would technically be level 0. I don't know if I'm saying that appropriately.
That's how ACOG is describing it
Yes.
on their website,
Yes.
yeah.
So it would really, because there is, I think, some movement afoot to do licensing of birthing centers, it would be most appropriately addressed in that way, not in this bill.
Thank you.
Representative Thompson. And then we're going to move on to the last bill. Thank you.
Thank you, Madam Chair. So my concern is that, in the early 2004, 2005, when a lot of the hospitals in Michigan wanted to become magnet hospitals, and they thought it was so wonderful because when they achieved magnet status, they would have more customer satisfaction, better patient outcomes. And then what ended up happening was they lost a lot of nurses because they intended to only hire bachelor degree nurses, which pushed a lot of associate degree nurses out and LPNs out. So I've talked with a lot of hospitals that are now rethinking that, and they've actually been hiring back the LPN and the associate nurse. Would this play a role in that? Could this affect nursing when we're already at a nursing shortage in Michigan because of the different levels of standards?
Yeah. I mean, I think it's a little bit of a different thing than magnet. I mean, this is more of a quality and safety issue. So we just need patients to know what level of care they can get at that hospital, and if they're expecting this level of care, but the personnel and the capability of that hospital is not there. I think that's all it's really going for. Does that? I don't know if that answers your question.
It does. I just I'm just very concerned about a nurse's autonomy and the levels of care that they can get. We'll talk later.
Thank you.
Thank you.
Thank you. Supporting the bill is Michigan League for Public Policy. Thank you for your testimony. We appreciate it. Finally, today we have House Bill 4728, which relates to HIV testing for breast milk donors. The idea for this legislation was brought to me by a hospital in my district, Bronson Methodist Hospital, which operates one of 30 breast milk banks in the entire United States. To speak to why this legislation is necessary, we have Sarah Clark, System Manager for the Bronson Mother's Milk Bank. Thank you for joining us, and begin whenever you're ready.
Thank you for allowing me the opportunity to speak today, and thank you, Madam Chair, for bringing this bill before committee and for sponsoring the bill. My name is Sarah Clark, and I am the manager of Bronson Mother's Milk Bank located in Kalamazoo. The Bronson Mother's Milk Bank was established in 2006 as a result of a Bronson lactation consultant's vision to significantly improve the incidence of necrotizing enterocolitis in the neonatal intensive care units. Nonprofit milk banks are somewhat rare, so we're extremely fortunate in Michigan to actually have 2 here. Not all states even have one. There are only 32 in all of North America. That's the whole continent of North America, not just America. We are accredited by HBANA, which is the Human Milk Banking Association of North America. Guidelines for human milk banking are developed by HBANA in consultation with the CDC, the FDA, and the American Academy of Pediatrics. So a little bit about us, because we are rare, not everybody understands exactly what we do. So many people confuse us with nutrition or milk rooms who will prepare feeds that are then distributed to neonatal intensive care units. Milk banks, however, work directly with donors to receive, pasteurize, and dispense breast milk to neonatal intensive care units and mother-baby units, in addition to outpatient infants. Last year, we had a banner year. It was something else through the pandemic and supply chain challenges. We approved 432 donors, which was significantly higher than the year before. We love our donors, and Michigan truly has a heart for donating breast milk. We were able to dispense 320,000 ounces of donor milk to our customers. That was an increase of about 22% from the year prior. Every year our dispensation increases. This was our highest annual dispensation ever, and working with a staff of only 2 to 3 staff members, not including myself. So I like to say it's a small department but a huge operation. We serve 20 hospitals within Michigan, including Helen DeVos, Botts Children's Hospital, Henry Ford, Hurley, and Munson, just to name a few. We also have a variety of hospital customers from across the country, from Connecticut to Arkansas. Our primary population are neonates in the intensive care units, but we also have a partnership with the Michigan Department of Health and Human Services, Department of STI and HIV, to supply donor milk to babies of mothers with HIV. This program aligns with a major part of our mission and is very important to us to ensure that we have enough milk to sustain our obligation. And truly, that's what is the backbone of the request of this legislation. So we requested this to eliminate the barrier of repeat HIV testing for our donors and moms feeding their own children in NICUs. And yes, you heard that right. Moms who are feeding their own children in NICUs are also subject by the same health code that the milk banks are. So that mandate requires HIV testing every 3 months. Even after your initial testing, after it was negative, we will approve donors. We are assured that pasteurized donor milk is safe, and this is based on public research. A study published in the Journal of Human Lactation by Orloff, Wallingford, and McDougall tested the HIV virus that was within donor milk under pasteurization. It was determined that the donor milk, which undergoes a pasteurization process that is exactly the same as what HBANA milk banks, our milk bank, also Henry Ford Milk Bank, uses, completely deactivates the virus. Additionally, in 2017, a policy statement by the American Academy of Pediatrics entitled Donor Human Milk for the High-Risk Infant, Preparation, Safety, and Usage Options in the United States states, and I quote, the processes used in pasteurization of donor human milk are highly effective in removing viral infectious contaminants. And they use 5 citations for this one statement. Additionally, we are mandated by Habana to obtain a series of initial labs that includes hepatitis B and C, syphilis, HTLV, and HIV 1 and 2 as part of the screening and approval process. That will never change. We are the only state that requires HIVs at the frequency of every 3 months. We partner with various labs for donor convenience. That is one of the things we do to try to support and promote donation, because it truly is a donation out of the kindness of somebody's heart. Producing breast milk and the quantity that it takes to donate takes a lot of hard work and truly the kindness out of their hearts. Each test ranges from about $16 to $246 depending on the lab that the donor chooses. So if we were to average that out, the cost to the milk bank would be approximately $37,000 annually for a single test. If a donor were to follow through with donation for an entire year, the cost would be around $112,000. Habana milk banks are not profit. Therefore, we're only extending a processing fee to the customer. The lower we can keep our costs, the cheaper the milk is. Hospitals do not hospitals do not charge patients for donor milk. So that donor milk that we're supplying to the Helen DeVos and to the Mott's, they're not charging the patients for that milk. So despite the cost to milk banking, the burden on donors is significant. Some of our donors are from the Upper Peninsula. So for Bronson, our donors span from South Haven to St. Clair Shores, all the way up to the UP. And some of them, it takes over an hour just to get to a lab. And to ask them to go every 3 months for something that is unnecessary and we know is deactivated by the pasteurization process is a really big ask. There's anxiety. I'm sorry.
If you can
speed it up.
Yep.
Okay. Yep. So basically, we lose donors because of this requirement. One thing I want to add is that there is the fiscal impact to the state is negligible. This would reduce barriers to donation. The more milk we can have, the more milk we can provide. Thank you very much.
Thank you so much. We have a couple cards to read in supporting the bill: Michigan Health and Hospital Association, the HIV/AIDS Alliance of Michigan, and Michigan Council for Maternal Mental Health, as well as the Department of Health and Human Services. Thank you, everyone, for your testimony. This is especially personal to me, as my mother taught obstetrics nursing at our community college for 36 years and shared with me a lot of these disparity issues over my time growing up. The remaining bills in our maternal and infant health package we did not have time for. We will take up in committee next week, October 26th. And if you have any questions or suggestions for the bills we heard in testimony today or on the remaining packages, please reach out to the bill sponsor. Representative Vanderwall moves to excuse absent members. There being no objection, motion prevailed by unanimous consent. There being no further business before the committee will stand adjourned.